Hi everyone, welcome back to the Quality Nursing channel. My name is Kwa, and today I've got an exciting video for you all. I'm making this video all about EKG. This will be very useful for newly graduate nurses who will soon be joining the workforce. Either you guys joining the ICU, med-surg floor, telemetry, L&D, any kind of floor. This video will help you guys not only pass the proficiency test that the hospital require you guys to take regarding EKG, but also it will be very useful for you guys to be able to work on the floor and able to identify and recognize the abnormal EKG rhythm. Also, this video could be useful for nurses who need a fresh up on their EKG as well, because I know I have been an ICU nurse for almost 2 years, and I know that every hospital require you guys to take the EKG exam every year in order to remain working on the floor. Specifically for my case, it will be an ICU EKG test, proficiency test, and we take it every year. Or if you guys are planning to take a travel nursing assignment, most agency nowadays require you guys to take a proficiency EKG test before you guys are accepted for that travel assignment. And lastly, if you guys are preparing to take your CCRN exam or planning for CCRN school interview, this will be a super useful video for you all. And so grab your favorite beverage, your favorite notebook, your favorite pen or iPad nowadays, and let's dive in together. So as I mentioned earlier, this video is all about EKG. This will be a quick recap for you all. I will go over each EKG rhythm, and we are going to primarily focus on how to identify them and a little bit about what they are, okay? So with that being said, let's go ahead and move right next to the next slide. Okay, so minor concepts about EKG before we delve into each of the rhythm. It is so important that you guys understand each of these concepts. So PR again, or I know that you already know, so it's just reminding you. So PR interval is going to be 0.12 to 0.20. This is going to be equivalent to 3 to 5 small boxes. PR interval is basically the time taken for the electrical impulse to travel from the SA node to the atria, AV node, and into the bundle of His and stimulating ventricular depolarization. Depolarization is the contraction. So basically, PR interval is the time it takes for the electrical impulses to travel from the beginning of the SA node to the beginning of the QRS complex. Okay, so 3 to 5 small boxes. QRS complex is 0.06 to 0.12. This is going to be 1.5 to 3 small boxes. I forget to mention that each small boxes, if you can see on the right end of the slide, is equivalent to 0.04 second, and the big box is equivalent to 0.20 second. So QRS complexes represent the depolarization of the ventricles of the heart. So basically, it's the time when the heart is contract or when the ventricle contract, okay? We don't want this to be too wide, and because you know what, we will talk about it later. Next, the third one that's important that I want you guys to know, especially in the ICU, is the QT interval. This will, the time is, the normal time range is 0.36 to 0.44. It varies between male and female. So this is usually about 9 to 11 boxes. What is QT interval? This is basically the time taken for the ventricles of the heart to depolarize and then repolarize. So it's a time for the ventricle to contract and relax ventricles. So in the ICU, if you guys are already working or are going to be working in the ICU, we usually measure the QTC instead of the QT interval. The reason for that is because since the QT interval, it shortens at faster heart rates and it's lengthens at slower heart rates. So in order to have a more accurate measurement, we do the QTC interval. It stands for corrected QT interval in, yeah. You guys don't need to know how to calculate it. Usually the monitor, when you get hooked up to the EKG for the patient, it will show up the QTC interval. So basically it's like you guys take the regular QTC interval, the patient QTC interval divided by the square root square root of the R to R interval. So that when you get the QTC interval, but you don't need to remember that. Anyway, so normal for men, the QTC is 350 to 450 milliseconds, and in women is 360 to 460 milliseconds is normal. However, prolonged QTC is somewhere above 500. And why prolonged QTC is dangerous in the ICU, because sometimes in the ICU, we give patients Zofran, and Zofran is a medication to prevent nausea, and it can cause prolonged QT prolongation and can increase the patient risk for torsade de pointes. So it's basically another form of VTAC, but we will talk about that in a later slide, okay? So I want you guys to remember this. PR interval, 3 to 5 boxes, QRS less than 3 boxes, and QTC if above 500, increased risk for torsade, okay? All right, so let's move on to the next slide. Okay, so heart block. Heart block is so common in every single proficiency test that the hospital tests you guys, or even CCRN, the exam for critical care nurses. You guys will come across heart block, all 3 types of heart blocks. So know these heart blocks by heart and know what they are. So there's 3 types of heart block, but the second type is actually had 2 subtypes in it. So let's go to the first one. The first one is first degree heart block. This indicating a delayed conduction of the electrical impulse from the atria to the ventricle. So basically, there's a delay between the signal from the atrium, the upper chamber, to the ventricle, the lower chamber of the heart. So 3 points about first degree heart block that you guys must know. Prolonged PR interval, which is greater than 0.20, and PR interval that consistent, and there's no drop QRS. Okay, so what does that mean? So for example, the hospital test give you guys this 6-second strips, and you guys look at them. Okay, so you guys able to tell me PR interval, P from the beginning of the P wave to the beginning of the QRS complex. That is more than 5 boxes, right? 5 small boxes, right? And we don't want it's more than 0.20, because if it's more than 0.20, that means that the PR interval is prolonged, and that means that there's a delay in the transit signal of the atrium and the ventricle. Okay, so and you guys see that each of the P wave is followed by a QRS complex. So for that reason, there's no drop QRS complex. Okay, again, first degree heart block, prolonged PR interval that is greater than 0.20, which is greater than 5 boxes. PR interval that is consistent, meaning that the PR interval stay the same length. It's lengthen. It's not like a little bit and then bigger and a little bit and bigger. It stays the same length. And there's no drop QRS, meaning each P wave is followed by the QRS. So there we go. You guys got the first heart block. Okay, now we are moving on to the second degree heart block. So this is the one that people often get confused between the second and the third degree heart block, and you guys will know why. So second degree heart block is basically intermittent failure of the atrial impulse to conduct to the ventricle. So sometimes the atrial signal, it just failed to be sent to the ventricles, and due to certain heart diseases or underlying heart condition, and that resulted in second degree heart block. There are 2 types of second degree heart block, type 1 and type 2. Type 1 is morbid type 1, also known as Wienkebach. So for this type 1, you guys need to remember from me, PR interval is lengthened but not consistent, and there will be a dropped QRS. So what that means is that the PR interval is lengthened. When you hear the word lengthened PR interval or prolonged in PR interval, immediately think it will be greater than 5 boxes, greater than 0.20 seconds. So as you can tell, the PR interval in the first morbid type 1 is greater than 5 boxes, and then it's not consistent. It's getting progressively longer. It's not staying the same length. So that's why it's lengthened. It's not consistent. You guys can see that the PR interval is getting progressively longer and longer and longer, and boom, there's a disappearance of the QRS complex. So we call it a drop QRS complex. All right. So type 1 of the second degree heart block, Wienkebach, PR interval lengthened, not consistent, and there will be a drop QRS. Okay. Second degree heart block, type 2, morbid type 2. So the difference between the second degree heart block type 1 and type 2 is that the PR interval is consistent and it does not lengthen. So what does this mean? So the pure interval itself is still prolonged. It's still greater than 0.20 seconds, right? It's still greater than 5 boxes. However, the pure interval stay consistent. It's compared to type 1, the pure interval get progressively longer with each beat, and then there's a drop QRS. For the type 2 morbid, type 2 of the second degree heart block, the pure interval stay consistent, the same with each and every beat, and then boom, there's a sudden drop QRS, unlike type 1, if you guys looking at the picture at the moment. Okay. So that's second degree heart block. Again, let's do a quick recap. Type 1, Wackenbach or Mobis type 1, PR interval is lengthened, not consistent, and drop QRS. Type 2, PR interval is consistent, and drop QRS. Keep in mind, both Mobis type 1 and type 2, the PR interval is prolonged, meaning greater than 0.20. So type first degree heart block, second degree heart block, all of them, the pure interval is greater than 20, greater than 5 boxes, okay? You see, greater than 5 boxes, more than 20, 0.20 second. All right, next, we have third degree heart block. Third degree heart block, aka complete heart block. So this is a medical emergency, you guys. Remember that there's no relationship between the P wave and the QRS, and there will be drop QRS, and the heart rate is usually less than 50 beats per minute. The heart rate here is referred to the ventricular heart rate, okay? So as you guys can see in the picture I posted here, the P wave and the QRS are independently beating. The atrium is beating by itself, and the ventricle is beating by itself. So there's no relationship between the P wave and the QRS. So there's so many P wave, and then there's a P wave before a QRS, and then you have 2 P wave right next to each other, and there will be no QRS complexes. So for the third degree heart block, you guys need to remember that this is a medical emergency. There's no relationship between the P wave and the QRS. There will be a drop QRS, and the heart rate is usually less than 50 beats per minute. Okay, so electrical impulses generated in the atria fail to conduct to the ventricle, resulting in an independent and often slower ventricular rhythm. So that's what I had. The atria and the ventricle beat independently of each other, leading to a slower ventricular rate and usually a faster atrial rate. So why is it a medical emergency? Because there will be a reduction in cardiac output, and it will hemodynamically affected the patient. The patient blood pressure will drop, and the perfusion, because of the low cardiac output, the perfusion will reduce, and the patient can be altered mental status, and lead to many other issues as well. So that's why it is a medical emergency. And also the heart rate is less than 50, accompanied by a low blood pressure. So we need to treat that, okay? All right, so let's move on. Okay, sinus tach versus SVT. So this is also very important, you guys. I know that it's very easy to identify sinus tach and SVT. However, a lot of us are often getting confused between the rate. So sinus tachycardia, obviously, if the heart rate is more than 100, it's sinus tach. But sinus tach, the range is 100 to 150. Okay, so given that the R-to-R interval is regular, meaning that the R-to-R interval in each of the QRS are the same length. So sinus tach, heart rate 100 to 150, and supraventricular tachycardia, which is atrial tachycardia. Fun fact, supra is above, and ventricular is our ventricle. So supraventricular meaning above the ventricle, tachycardia referring to the atrium. So that's why they also have another name calling themselves atrial tachycardia. And the heart rate for SVT is 150 to 350 because the heart is beating so fast because of the atrium as well. So usually the patient blood pressure can be hypotensive and can be affected, can be low because of SVT. So that's why we usually cardioversion the patient or giving them adenosine, okay? All right, next. Okay, so AFib and A-flutter, another very easy concept, but you guys need to be able to identify them. Okay, so let's go ahead and move on to AFib. AFib is basically a chaotic electrical impulses from the atria is just quivering. It's just not sending or beating and sending the electrical impulses it's supposed to do to the ventricle. It's just quivering. Okay, so it's not contracting effectively and sending the blood and the electrical impulses to the ventricle. So there's an absent in the P wave. So what to remember, AFib, absent P wave. So you guys look at the monitor and you see AFib rhythm. You guys see QRS complexes with like quivering P wave. That means that the patient is in AFib. That means that the patient is in AFib, okay? The first picture. B, A flutter. So unlike AFib, where the atrial activity is chaotic, in atrial flutter, there's a rapid and regular atrial rhythm, okay? So it's not chaotic, the atrial rhythm in A flutter, but rather it's fast and regular atrial rhythm. So sometimes the heart rate can show up on monitors like 240 or to 300 beat per minute. However, that is actual actual ventricular rate is much lower. So you guys will see a famous sawtooth pattern that we all learn in nursing school. Okay, so that's how you differentiate between the AFib and A flutter. A flutter is like sawtooth. You guys will see sawtooth, whereas AFib, the chaotic electrical impulses from the atrial, you guys will see quivering P wave, and actually there's no P wave, so it's just quivering lines. All right, next, AFib with RVR. So basically, these patients already have AFib, meaning chaotic and unorganized electrical impulses sending from the atrium. So it's not beating effectively the atrium, and also the patient has a rapid heart rate in the ventricles of more than 100 to 180 beats per minute. So these patients have AFib, and then the chaotic electrical signal from the atrium causes the ventricular to contract rapidly. So these patients, we call them that they are having AFib with RVR. Usually, if their blood pressure is unstable, what we would usually do in the ICU is we would get an EKG immediately, and then we give them either a midorone, put them on a midorone, or metropolo bolus, things like that. Okay, if the blood pressure is okay. But yeah, so it's basically, again, no P wave for AFib. You guys will see like quivering line like that in the P wave area, and you guys see a heart rate of more than 100 to 180 beats per minute, okay? So that's AFib with RVR, super easy. All right, next we have junctional rhythm. So junctional rhythm, we're usually not being taught in nursing school, but this is important to know because it will come up on the proficiency test, in every single test, and it's common to happen in patient in ICU as well, because they usually have a weaker heart. So normally the natural pacemaker of the body is the SA node. SA node initiate electrical impulses for the atria to contract, and then these electrical impulses travel through the AV node. So SA node first, then AV node, and then to ventricular. So that's how the electric signal go through the heart in order to make the ventricle contract and pump blood outside to the rest of the body. So in a junctional rhythm, the electrical originate from the AV node instead of the SA node. So it skipped the SA node, maybe because there's some underlying heart disease or some issue with the SA node area. So key points to remember for junctional rhythm in order for you to pass the test: no P waves or inverted P waves, and QRS less than 0.12. So I know the AFib has no P wave as well. So how do you identify the junctional rhythm and the AFib rhythm? You look at their line. The line of the line between each beat will be more flat compared to the AFib, because AFib, the atria is quivering, so that's what it's causing like a wiggly, very spiky line, compared to junctional rhythm where there's just completely no electrical impulses from the SA node as all. So that's area of the P wave line is flat, or it will be inverted down. Okay, so it's either inverted or no P wave, and the QRS is narrow. The QRS is very narrow because because the electrical impulses from the AV node to the QRS is not as strong as from the SA node to the QRS to the ventricle. Okay, so it's usually narrow, and it's usually less than 0.12. So junctional rhythm is, if the test asks you about junctional rhythm, it will be 40 to 60. If they ask about accelerated junctional rhythm, it will be 60 to 100. And if it's a junctional tachycardia, it will be 100 to 150. Okay, so basically, again, junctional rhythm is electrical impulses originated from the AV node instead of the SA node, therefore lead to no P waves or inverted P waves, and the QRS is narrow, less than 0.12, less than 3 boxes. Junctional rhythm is 40 to 60, accelerated junctional rhythm is 60 to 100, and junctional tachycardia is 100 to 150. Okay. All right, next, idioventricular rhythm. So idioventricular rhythm, also known as escape rhythm, SA node and AV node both fail to generate electrical impulses. So like I mentioned earlier, with junctional rhythm, SA nodes fail to generate electrical impulses, but then AV node take over. AV node take over the SA node job. However, in idioventricular rhythm, this will be on the test too, you guys, any test. Both SA node and AV node failed to generate electrical impulses. So that leads to the emergence of a ventricular pacemaker that generates electrical impulses to drive ventricular contraction. So basically, the ventricle, the lower chamber of the heart, assume the roles of the primary pacemaker of the heart. So it's self-generated electrical impulses, self-generated contraction, and pushing the heart to the rest of the body. So when the patient in this rhythm, they usually not doing good because cannot stay there long. So we have to do something for them immediately. So key point to remember, no P waves and QRS is widened more than 0.12, okay? And they need cardiologist stat. Idioventricular rhythm, heart rate is usually between 20 to 50. Accelerated idioventricular rhythm is usually between 50 to 100. So you guys can see they will often have absent P wave, no P wave, and the QRS is going to be wider than 0.12. Whenever QRS is widened, that's not a good thing, okay? Should be less than, should be between 3 to 5, should be between 1.5 to 3 boxes, less than 3 boxes, less than 0.12. So that's idioventricular rhythm and how to identify them on the test. Okay, so VTach, the famous VTach, ventricular tachycardia. So we've learned about VTach, VFib, asystole in nursing school. These are code situation rhythm. These are life-threatening rhythm that you guys must know already. So again, VTach, medical emergency, this is a shockable rhythm. What does it mean, a shockable rhythm? A shockable rhythm is a rhythm that we can shock. Ventricular rhythm with a rate exceeding 100 beats per minute, although it can be often much faster, ranging from 150 to 250, and the QRS is very widened. Widened mean more than 3 boxes for QRS. So if you see VTach on the monitor, either VTach or Torsat, Torsat is the second picture, it's also categorized as VTach, meaning widened pulse and fast ventricular rate. So if we palpate the pulse of the patient, okay, if the patient has a pulse and the patient is altered mental status and the blood pressure is low, you guys need to act fast. We're going to do synchronized cardioversion, okay? We're going to do synchronized cardioversion to snap them out of that rhythm. So if the patient is asymptomatic, they have VTach, first of all, we need to check the EKG lead. Is that correct? Then we consider giving them lidocaine or amiodarone. So if the single cardioversion is failed, we can also consider giving them lidocaine or amiodarone. So we check the pulse and there's no pulse. Obviously, we need to follow ACLS protocol and consider deliver shock to shock them out of the rhythm and keep continuing doing CPR and then give epinephrine to, kick all of the receptors so that the heart can start beating again. And then we give amiodarone and then, of course, CPR again. So, and then, of course, shock again, depend on the situation. So pulseless, we always do ACLS protocol, but consider, because it's a shockable rhythm, so we need to shock them, right? And then CPR, because there's no perfusion of the body, so need to do CPR and epinephrine to kickstart the heart to beat by itself again. And amiodarone is to push, if the shock is not working, we give them amiodarone to keep them out of the abnormal rhythm, and then CPR again. Okay, so VTach, life-threatening, 2 type, ventricular VTach, regular VTach, and then the Torsat. What caused Torsat? Again, prolonged QTC, more than 500, okay? It does not necessarily mean that it will lead to Torsat, but they have a higher and increased risk of having Torsats. So if they were to have like a magnesium level of like 1.8, and then their QTC is like 600, and you guys give them Zofran, oh my gosh, the patient can go into torsade, VTAC, and they will have a critical situation there. So when you guys give medication that can affect or prolong the QT interval, remember this, okay? And also, if the patient in torsade, usually in the ICU or during the code, we will give them magnesium as well. All right, next, ventricular fibrillation. So this is another life-threatening rhythm. This is also a code blue rhythm as well. Usually patient in V5, they are pulseless. So this is also a shockable rhythm. You guys can see the picture right here. It's chaotic, rapid, and uncoordinated electrical activity in the ventricle of the heart. So unlike AFib, V5 is when the ventricle, the most important chamber of the heart, quivering and cannot send the blood out to the rest of the body. So the ventricle quivering ineffectively instead of contracting normally, and leading to a loss of effective pumping function and therefore reduced cardiac output and no perfusion to the rest of the body. So of course, again, if we see this rhythm, always do a post check, and then we follow ACLS protocol where we would put them on the pad, do CPR immediately, put them on the pad, shock them to snap them out the rhythm, and consider epinephrine, amiodarone, and CPR. So basic running codes, okay? And then of course, during that time, looking at their labs and what is their acid base, giving them bicarb, magnesium, calcium, slam them with medication that can take them out of the situation, and then identify what is the root cause of their issues. So that's a VFib. And then asystole and PEA. So guys, this is the last slide. Stay with me. Asystole and PEA. So asystole basically means flat lie. There's no electrical activity or pulseless, or there's no electrical activity and the patient is pulseless. So it's not a shockable rhythm. There's no rhythm for us to shock them out of it. So we have to do CPR, of course, give them epi to kickstart the heart again. And of course, look at the labs again and do everything we could. Look at the H and T's and look at all of the different possible ways we can do during the code so that we can snap them out of the asystole situation. Next, we have PA's pulse electrical activities. There is a electrical activity in the heart and shown on the monitor that we can see, but when we palpate the pulse, there's no pulse. Okay, so there's still electrical activity in the heart, but there's no contraction or pumping of the hearts going on. So therefore, there's no cardiac output for the patient. So again, we need to do ACLS protocol. We need to do CPR and epi because there's a pulse. So it's pulseless electrical activity. There's electrical activity, so we don't shock them. Okay. So we do CPR, epi, and again, looking at the labs and do the H&Ts and think of what can we do to help the patient out of that situation and to resuscitate the patient. And okay, so before I sign off, I want to leave you guys with one last thing. Epinephrine is given every 3 to 5 minutes during codes, okay? It's not every 2 minutes. CPR and pulse check is every 2 minutes, but epi is 3 to 5 minutes, okay? All right, I hope you guys enjoyed the video today, and please follow me on all of my social media. I will have a whole I will have a whole cheat sheet posted in the bio of my Instagram. So please check out my Instagram, click on the bio, and then you guys see the link. You guys can download it for free. It will combine all of the rhythm here today, so you guys can prepare for your proficiency test or EKG test in general. Okay, and thank you so much for watching my video. Please subscribe and leave a comment. Thank you. Very nice.